Okay, good morning, everybody, and welcome to today's Cheang, Shanks and Pathological Society Pathology Grand Rounds. Our usual host, Professor Sarah Coupland, is away in Australia, and she's asked me to fill in for her. I'm Mark Arends. I'm the previous president and currently the General Secretary of the Pathological Society. So today it gives me great pleasure to introduce our speaker, who is Dr. Maggie Cheang. Maggie's internationally recognized for integrating molecular pathology and biomarker science into clinical trials to advance precision medicine in breast cancer. Originally, she's from Vancouver. She earned her BSc in cell biology and genetics at the University of British Columbia in 1998, an MSc in bioinformatics at the University of Hong Kong in 2000, and a PhD in pathology at the University of British Columbia in 2008. After that, she undertook postdoctoral research at the University of North Carolina at Chapel Hill. And following that, she established herself with an independent program of research in London in 2017 and is now reader in cancer trials and molecular diagnostics at the Institute of Cancer Research, where she heads the Integrative Genomic Analysis in Clinical Trials Group and serves as the Translational Genomics Lead. Maggie first gave this lecture to the Pathological Society at the Ghent meeting in June of this year. And it gives me great pleasure to introduce her, and the title of her lecture will be The Transformative Role of Molecular Pathology in Breast Cancer from Histology to Precision Therapeutics. Thank you very much, Maggie.
Thank you very much. Can you see my slide?
Yes, we can, but it's in the mode where we can also see the small strip of slides on the left. That's better. That's the full presenter mode. Thank you.
Thank you very much, Mark, for your fantastic introduction of myself. And it's an absolute honor to deliver the grant, which is based on my Oakley lecture this year, the lecture series which was created in Professor Oakley's name, which I think is really much resonating myself a lot because it's actually it stood everything with value in pathology today: the rigor, critical thinking, clinical relevance, and scientific integrity. So here is a slide, a little bit in terms of demonstrate my growth in terms of the foundation during a time when molecular tools started to transform how we understand, diagnose, and treat disease. But when I work in discovering intrinsic subtypes on the development of AI-driven integrated molecular diagnostics, I've been fortunate to contribute to this progress. So this grand round lecture is my way to honoring that legacy and continuing it as we carry those values forward into the future of precision medicine. And here is a key disclosure. I'm a co-inventor of the PAM50, which was commercially licensed as Prosigna in 2009 and has been in clinical use since 2013. Traditional histopathology gave us a very solid diagnostic foundation, but for treatment decisions, especially in ER-positive breast cancer, morphology alone is not sufficient. And this figure from TCGA project shows how breast cancer classifies as invasive ductal carcinoma actually span multiple intrinsic subtypes. So two patients with the same histological diagnosis may be fundamentally different in terms of the tumor biology and therapeutic needs. And this molecular heterogeneity is also observed across other histological subtypes, such as invasive lobular or mucinous cancers, reinforcing the point that morphology based on H&E alone doesn't capture the full molecular biological picture. Biomarker research has changed the game. Our 2009 reported JNCI paper demonstrating that molecular subtypes carry a very distinct prognosis. For example, the numinal A has a very much better outcome than numinal B, despite a very similar ER expression status and as well as histologically. So these insights have had direct impact on clinical practice. And today, tools like this and other gene expression signatures have helped guide decisions on whether to use his chemotherapy, which endocrine therapy approach to take, and increasingly how to interpret this new trial data. And this line shows how far molecular pathology has come in cancer research. What you can see here is a snapshot of the data we now work with daily: gene expression, protein signaling data, DNA methylation, DNA mutations, and copy number changes. Each technique tells us something different about the tumor. And when we put them all together, we get a much clearer picture of its biology. We now use this information to also design trials, match patients to treatment, and even support clinical decisions near in real time. As molecular pathologists working with data scientists, our role has grown significantly. We help shape the research questions in both prospective and retrospective studies, guide the data analysis, as well as make sure that what we learn from the tissue really benefits patients. Here is an overview of how we breast cancer leads the way in this context. Breast cancer was one of the first cancers where gene expression profiling really revealed the distinct biological subtypes, a breakthrough made possible through close collaboration between the pathology as well as access to well and native tissues put together by the pathology department. Over time, we have been able to build on those early discoveries. Just as importantly, breast cancer has also led the way in how we design biomarker-driven clinical trials. Studies such as POETIC and PATHOLOGY, which I will touch on in the second part of my talk in ER-positive breast cancer disease, have shown how molecular pathology can directly inform patient care. This slide illustrates a typical workflow for gene expression studies. Tumors are collected in theater, and tissue is set aside not only for diagnosis, but also for molecular profiling. We extract RNA and DNA and analyze them using platforms such as microarrays or now RNA sequencing. The data can then be explored using unsupervised clustering methods to discover the natural subtypes like intrinsic subtypes, or supervised method like oncotype and MammaPrint to develop predictive tools. Both approaches are now central to how we classify ER-positive tumors as well as other tumors and design trials. And this is why I think breast cancer today could be a model for precision oncology about other disease. So first, I want to give a little bit in terms of how we have defined intrinsic subtypes and demonstrate the clinical relevance and how it becomes clinical tools. As always, breast cancer intrinsic subtypes matter. These intrinsic subtypes were first discovered through unsupervised clustering of gene expression profiling data, and it was first reported by my postdoctoral mentor, Professor Chuck Peru, in 2000. This figure comes from one of the earlier studies almost 18 years ago using the customized microarray in Stanford. It was based on the analysis of an intrinsic gene list capturing genes with high variation between tumors, but how low variation within the same patient. From this, we identify 5 consistent subtypes: numero A, numero B, HER2-enriched, basal-like, and normal-like. These subtypes reflect the tumor's intrinsic biology rather than differences in histology or treatment. Importantly, they have been validated across multiple independent datasets and platforms. And this figure shows a variation in expression of one of the earliest data. Again, this is only like 100 genes across 84 experimental samples. The dendrogram illustrates how these samples cluster based on similarities in the gene expression patterns. Samples from the same patient, those collected before and after chemotherapy, are highlighted in red. The 2 primary tumor and lymph node metastasis pairs are shown in light blue, and 3 normal breast cancer clustered together in light green. And this is where we actually identify the normal-like breast cancer subtype as well. This discovery has been cited by the American Society of Clinical Oncology as an important research advance in breast cancer. And this also slide shows just a little bit shows a series of key validation studies we carry out to assess the clinical and biological value of the intrinsic subtypes before they were brought into the clinic. So also many other studies demonstrated by independent groups as well. It was almost 15 years to turn this signature into a clinical grade classifier. In the FDA approval test, each run also includes a standard reference sample to ensure technical robustness. In the next slide, I will show you a little bit how the bioclassifier works behind the scenes. Once the subtypes were, so during the development, once the subtypes were well established, the next challenge was, for us, was to develop a classifier that could assign a subtype to an individual patient reliably, reproducibly, and in clinically practical way. So not like a classical, like in a population base where you normalize gene expression in the population and then you assign against a backdrop of a population. That would not be robust in a clinical way. So this is how PAM50 was built, using a central-based algorithm trained on 50 genes that we have selected that best represent each of the intrinsic subtypes. The classifier compares a new sample's expression profile to the average, which is called centroid of each subtype. To maintain the consistency, we anchor the system to a robust reference set. This allows a very single tumor to be classified accurately without needing to process it alongside a full cohort. That step was essential for clinical translation, is what took us from research clustering to real-world diagnostics. And this slide shows an example of how these molecular insights can be translated into clinical tools. And on the right is a typical report that a patient received if they have done the ProSignal in ER-positive ER-positive HER2-negative early breast cancer. In this example, the patient is classified as luminal A with a very low recurrence risk score, indicating a very low risk of distant recurrence. That supports a treatment decision of endocrine therapy alone or without chemotherapy. These results have also been validated externally independent by larger collaborative group in large clinical studies such as the Cheang and the ABCSG in Austria, which leads the test to be now incorporated into major international guidelines such as ASCO, in ISMO and the NHS. England is a clear illustration of how a discovery in using molecular pathology can evolve into a standard component of patient care. The next image here, I want to highlight a key limitation of bulk molecular subtyping. We give a tumor a single label, but in reality, it's a mosaic of very different, possibly different cell populations. You can see a simplified example of a tumor containing both possibly luminal A and luminal B features coexisting in space. In our earlier PAM50 work, which I just give a brief introduction, the classifier captured the dominant transcriptional signal, essentially the loudest voice in the tumor. So what we are learning now is that, especially through spatial profiling, is that tumors are not uniform. Different regions may have distinct biology, driving treatment response and ultimately resistance. So the question is, what if we could actually see that heterogeneity, not just infer it from bulk data, but map it directly within the tissue? And that's exactly where the field is heading, moving beyond traditional bulk intrinsic subtyping, integrating spatial and multi-omics tools to truly capture intratumoral complexity and refine how we understand response and progression. So now in the next part of my talk, I would like to shift the focus to my current research program at the Institute of Cancer Research, London, where we are tackling both intertumor and intratumor heterogeneity and how these layers of complexity shape treatment responses and resistance. I will start by taking you into the case of triple-negative breast cancer, where integrating molecular subtypes with the mutational landscape is starting to transform how we design trials and treat patients. Triple-negative breast cancer accounts for roughly 1 in 5 breast cancer cases. It's called triple-negative because these tumors lack estrogen and progesterone receptors as well as HER2 amplification, meaning many standard targeted therapies for breast cancer are ineffective. Clinically, TNBC tends to behave more aggressively and relapse earlier. Around 10 to 20% of these patients carry a BRCA mutation, which provides opportunities for targeted approaches such as PARP inhibitors or platinum-based chemotherapy. However, for the majority, represented by the question mark here, we still lack a clearly defined personalized treatment path. And this is the motivation behind the network, applying molecular profiling to dissect the biology of TNBC, aiming to develop possibly a more precise classification and smarter biomarker-driven trials in the future. So the work that I want to next discuss is about the work where we have done in this clinical trial called TNT, where we compare 2 chemotherapy agents, carboplatin and docetaxel, in patients with advanced triple-negative breast cancer. The goal was to determine whether certain biological subgroups, particularly those with BRCA mutation or related features, may respond better to one treatment than the other. When we look at the overall population, the two drugs perform similarly. However, among patients with inherited BRCA or BRCA2 mutations, carboplatin shows a markedly higher response rate, nearly double that we've seen with docetaxel. Interestingly, other markers we explore, such as BRCA promoter methylation or low BRCA1 mRNA expression, this did not predict benefit. So what we found that gene expression subtype, especially basal-like versus non-basal-like as classified by the PAM50, do actually have some association with the treatment response, particularly to docetaxel. So what this last translational study taught us is that BRCA mutation testing is essential for guiding therapy in advanced TNBC, and that incorporating gene expression subtypes may further refine treatment selections. Then I would like to share some important work led by my former PhD student, Holly Torpey, which we carried out during her time in my lab. In this study, we visited TNT trial data, integrating multi-modal biological information to better predict excuse me, which treatments are most likely to benefit which patients. We focus on two aspects: the level of immune activity within the tumor, essentially how many immune cells had entered the tumor microenvironment, and the tumor's capacity to repair DNA damage, known as the DNA damage response or short-term DDR. We observed that tumors with stronger immune activity tend to respond better to docetaxel. In contrast, those showing signs of impaired DNA repair genes or higher DNA DDR scores appeared more sensitive to carboplatin, particularly in patients who had not received the prior chemotherapy. By combining these features, we were also able to group patients into 6 biological subsets, 2 of which show clear tendencies toward one treatment over the other. We also note that samples from primary tumors were not always reliable for predicting response and recurrence, especially after the chemotherapy exposure, an important point for clinical interpretation. And this type of integrated profiling, bringing together immune and molecular features, may help guide more individual treatment approaches in triple-negative breast cancer. This brings us to one of my growing research interests, developing biomarker-rich clinical trials, starting with triple-negative breast cancer. Phoenix trial is an ongoing trial that we are running, managed by ICL-CTSU in collaboration with Professor Andrew Tuck and Shiba Ersad from King's College. Phoenix trial is a very good example. It focuses on patients who still have residual disease after chemotherapy, those who haven't fully responded and may need more than standard treatment. Learning from tumors before surgery in Phoenix is patients with residual disease after neoadjuvant therapy receive additional treatments before surgery by collecting biopsies both before and after both before and after these treatments. We can study how tumors adapt, and only clinically, but also at the molecular level. And we also have following blood. So it is in the context of stream in terms of following cancer through the blood. We also use the liquid biopsy to track the tumor DNA after surgery. This allows to detect minimal residual disease early and potentially could guide follow-up treatments, an area where molecular pathology and data science are coming together to refine patient care is a very hot topic at this moment. Sorry. So this is really where the emerging hot topic in molecular pathology in trials right now. The idea is very simple but powerful. We are not just testing a drug, we are asking why it works and for whom. By measuring early biological signals and how quickly tumor cells are dividing and how active the immune response, we can start making treatment decisions sooner. And this is now this slide is actually still related to Phoenix, but I want to highlight in terms of the different primary endpoints that we are measuring in this biologically rich trials and why molecular pathology is very important. We can integrate data, RNA, DNA, proteins to build a truly comprehensive picture of this tumor. And finally, pathology is acting as a science, leading the science in trials. In studies like Phoenix, molecular pathology are not just behind the scenes processing the samples. We are now part of the broader team, helping to frame the biological questions, interpret what the data are telling us. This is a small study, but meaningful shift from working at the edges of trial design to contributing directly. I think molecular pathologists are now linking the molecular insights in patient and benefit. I think this is where our discipline can really make a lasting differences. Now, finishing negative, I want to shift us to the ER-positive breast cancer, where early biological signals as also where the results are really much driven by the molecular pathologies and how histopathology can just as revealing. In disease where relapse often happens many years after treatment, these early indicators may give us a very glimpse of long-term outcomes much sooner and help us tailor therapy more effectively from the start. Over 80% of breast cancers are estrogen receptor positive, and for decades we have relied on endocrine therapy therapies to reduce mortality. For premenopausal women, tamoxifen lowers the risk of breast cancer death by about 30%, while in postmenopausal women, aromatase inhibitor reduce that risk by around 40%. Yet where recurrence still occur, and sometimes because the tumor is inherently resistant to endocrine therapy, or sometimes because resistance develops over time. That's why the field also now very much focus on treatments, not only alone, but also to understand who is at risk and then how we can prevent relapse altogether with additional treatments. As I mentioned earlier in my talk, where we have now very much several validated gene expression-based prognostic signatures used in the clinic, including the Oncotype, EndoPredict, and ProSigna, many of which are now insured in also the UK NHS practice. This tool allows us to tailor treatments more precisely, particularly in situations where the benefit of active chemotherapy is uncertain. And this slide compares, show the results led by Professor Mitch Dowsett 10 years ago, which compares several well-known prognostic signatures, including our own, using the data from TransATAC. All these samples came from postmenopausal women who received adjuvant endocrine therapy alone. The aim was to assess how well each signature could distinguish patients at different risks of recurrence. As you can see, all of these assays perform well in stratifying the patients, but most importantly, each could reliably identify a group with a risk of recurrence below 5%, a level that most clinicians would regard as safely low risk and unlikely to require additional chemotherapy. The current adjuvant treatments planning rests on two main pillars. Hence, you can, on the left, which is a very simple cartoon that I draw, that is based on clinical pathological assessment and tumor profiling, as mentioned, from previous slide. It could be either Oncotype or ProSigna or EndoPredict. And this approach has really been effective in ER-positive, but these are all based on single sample bulk measurements, essentially averaging across the tumor. And of course, we now know that the biology is rarely that simple. So both clinical assessment that are based on baseline tumor, and these also, sorry, I forgot to mention that both of these assessment, clinical path and molecular profiling tools are based on baseline tumor characteristics before any treatment begins. And we are now already know that therapy itself can reshape the tumor biology. Hormone receptor status as well as the intrinsic sub can shift over time, yet we rarely reassess during the treatments until the tumor recur. So what appears high risk at baseline may behave quite differently once the therapy starts, and vice versa for the lowest tumor. So the key question is, can we capture and use these treatment-induced changes to make better adjuvant decisions early? Incorporating molecular evaluation during endocrinopathy as part of clinical trials could then be an important step toward that goal. Which brings you this last slide, where the POETIC trial was one of the largest pre-surgical endocrine therapy studies ever conducted, involving more than 4,000 women and ER-positive breast cancer in UK. This concept was simple: give 2 weeks of aromatase inhibitor before and after surgery and observe what happens biologically, and follow these patients in a long term after they have been treated with adjuvant treatments according to the standard of care practice. What made POETIC unique was that instead of waiting years for long-term outcomes correlating with the baseline characteristic, we could actually get an early biological readout. We measure Ki67, a marker of tumor proliferation at baseline, again, after just 2 weeks to see how the tumor responded. And that tells us a lot. Patients who Ki67 remain high after 2 weeks, shown by the orange line here, had roughly a 20% risk of relapse at 5 years. So a lack of early biological response was a strong indicator of poor prognosis. The key takeaway message here is that early biological response to endocrine can really serve as an almost real-time risk marker, one that could allow us to adopt treatment far earlier than we do today. So building on the foundation of POETIC, we are currently, there's a running trials called POETIC A trial, specifically targets the high group defined by the baseline Ki67 at high at baseline, remaining high after the neoadjuvant endocrine therapy, whose tumors continue to show high proliferation. This subgroup represents a biological high risk and potential endocrine resistant population characterized by a lack of early treatment response and substantially elevated risk of relapse, as defined by the Ki67. So for this reason, POETIC A, we also introduced the CDK4/6 inhibitor inhibition drug, testing whether adding the targeted therapy in this high-risk group can overcome this early resistance, improve long-term outcomes. And CD4, and we also included is a AirKit signatures. POETIC A was designed to screen over 12,000 ER-positive patients to identify those at high risk and then focus on the 2,500 whose tumors remain high proliferative after the aromatase inhibitor, and randomizing them to test whether adding beaver-cyclib improves outcome. But beyond the treatment, this trial also testing the signatures called AirKit, a molecular algorithm that we have designed to identify which patients are most likely to benefit from treatment escalation. So this is the study where I'm trying to test now a performance of a new biomarker signatures, which is developed by using the POETIC and is also another like next generation algorithm that I'm hoping that the performance would be validated. So how we developed the AirKit is we learning for ProSignal. Now upfront we try to design it as an in vitro diagnostic designed to run on a single FFPE sample, very much like the ProSignal test. The aim is to achieve a very tight standardization, robust normalization, and consistent performance across batches, all essential for clinical reliability. So in order to do that, we conducted a technical validation study, including pair and untreated samples from the POETIC control group to test precision and the reproducibility. Additional material from POETIC and pilot was used to estimate the prevalence of the AirKit resistant profiles. The assay is designed with practicality in mind that you can process anywhere from 1 to 10 samples per run, making it suitable for routine laboratory workflows. Here, I will just demonstrate what we anticipate the workflow. And conceptual AirKits use a modular gene signature. You can think of it as a similar like a Venn diagram capturing 4 biologically distinct resistant mechanisms: the non-numinal subtype, RB1 loss, cyclin E1 overexpression, and then high E2F activity signature, which are all integrated through a machine learning classifier. And I can talk a little bit more offline if anyone interested in terms of how AirKit was developed, and due to interest time, I have to make it very short. Sorry today. So building on, so next I also want to finish the third part of the talk is I want to demonstrate a little bit shift to how we actually integrated the spatial biology in our research. So building on the POETIC platform, we have set out to understand how ER-positive and HER2-positive now, the tumors that involve under therapy, not just when they respond, but how their biology changes. This multi-omics research program includes 342 patients, which is probably one of the largest cohort of this understudied subgroup of patients, giving us a unique view of how their molecular characteristics change over time. Our analysis centered on two key endpoints, the early Ki-67 change as a marker of biological response, as explained in the previous slide, and also long-term survival as a clinical outcome. So far, we have published two biomedicine studies, one examining how baseline tumor biology predicts the response and prognosis, and other linking the treatment-induced molecular shift to patient outcomes. For the final part of this talk, the spatial biology work that we are going underway would be also, I'd like to show this to demonstrate the next step. Where I truly believe where the molecular pathology pathologists can really lead the way in connecting the biological insights to clinical impact. On the left, you can see how tumor subtype changes after just 2 weeks of endocrine therapy. Many tumors that were initially classified as luminal B actually shift towards a luminal A profile in this ER-positive, HER2-positive tumors, even just 2 weeks of endocrine therapy, while those that are HER2-enriched tend to remain stable, which suggests that HER2-enriched subtype is the main driver to the endocrine therapy resistance. But then if you have a ER-positive, HER2-positive luminal B tumor, it could be likely that some of them would actually be very sensitive to endocrine therapy. So not all ER-positive, HER2-positive would have respond to endotherapy equally, which we have expected. And also, the next step is that clinically, what's important is that tumors that transition to luminal A, regardless of the starting point, are also associated with a significantly lower risk of recurrence over the long-term follow-up time, as demonstrated on the right on the Kaplan-Meier curve. But one of the key questions we also asked was whether the shift in this subtype simply reflects a reduced proliferation, as many would probably think, link a drop in Ki-67, or whether the different biological changes are actually at play. On the right, you can see that the average gene expression change after 2 weeks of endocrine compared with baseline group by whether the tumor shift by subtypes or not. Expected proliferation-related genes, shown in blue, decrease across all groups, dominate the signal, along with, however, a reduction in ER signaling. We also observe an increase in immune-related genes, marked in orange, in most tumors. We also observe an increase in immune, which shows relatively little immune activation. The most intriguing finding is this on the 2 red arrows, is that in some tumors, particularly ER-positive, HER2-positive, we see an increase in ESR1 ERB expression after just 2 weeks of therapy, which is very kind of much similar, suggests that the ER-HER2 crosstalk, which is have suggested by the field for quite a long time already. So this suggests potential active adaptation. Tumors using both ER and HER2 pathway to bypass treatment effects maybe, and underscores why on treatment profiling could potentially reveal dynamic biology that baseline analysis alone would completely miss, which is also signaling in terms of maybe in the next generation of clinical trial, we should really look at this evolution of tumor rather than just the baseline. So after seeing how tumors can rapidly adapt to therapy at the molecular level, even just 2 weeks, we wanted to go on a step further to understand whether within the tumor, those changes were happening. So we began with a technology called GeoMax digital spatial profiling, a very powerful platform that measures genes and protein expression directly in the tissue while preserving the spatial resolved context. It allows us to see not just what is changing, but where is happening within the tumor microenvironment. Before any measurements, we first identify regions of interest on each slide. This is where the molecular pathologists really played an important role, and I'm very lucky to be able to collaborate with Roberto Salgado to help us to actually select the regions of interest. And using the morphology markers, we highlight tumor cells, immune cells, and nuclear, and all together. We viewed by Roberto, the fluorescent and H&E images together to carefully select the biologically relevant areas. Because this study offers a really rare chance to explore the intra-tumor heterogeneity, we also deliberately select a diverse set of regions of interest, including tumor-rich regions, immune-dense zones, mixed areas, lymphoid aggregates, DCIS, and adjacent normal tissues that are all present in that one slide. Once selected, these regions are profiled on the DSP platform for gene and protein expression. In this project, we analyzed roughly about 10 to 12 regions per slide, giving us a very high resolution map of how different parts of the same tumor behave before and after the response to treatment be deferred. And we are still analyzing the data, and we are hoping to present very soon in a publication map form. But this is, I just want to show an example, and having mapped this molecular example of one of the sample that we have mapped these molecular changes through the spatial profiling. Even with a single case, you can see the morphology diversity is striking. At baseline, we see a mix of tumor and immune-rich regions. After treatment, though, an intrinsic interesting pattern emerges. The immune cells begin to cluster around blood vessels, yet we don't observe accompanying plastic structures that normally guide them into the tumor parenchyma. And this also reflects in the gene expression signatures as well. So this may help explain why we often detect higher immune gene signature in ER-positive tumors without a fully activated immune response. This is just a hypothesis. We have to test it. The immune cells are present, but spatially misplaced there, but not functionally engaged. And I think this is the rare area I'm looking forward to collaborate with molecular pathologists, and anyone is interested, please, I would love to speak to you. So to close, I will mention another active project in our group, one that brings all these strands together. We are now integrating the large volume of molecular, spatial data, and clinical data we have generated into an AI-powered analytical framework designed to help us interpret these complex patterns, tumor behavior more systematically, and also as a large language model, which could be ultimately support a little bit kind of better clinical research with the oncologists and clinical fellow who may be interested in doing some of this work and may not have that equipped in terms of that high dimensional data analysis experience. This slide gives an overview of the AI platform that we have been developing. It brings together the full range of data from the POETIC trial. It's really much driven by my soon former PhD student, Sison Su, and also our close collaborator, Farron Cardozo from the Integrated Pathology Unit at the University of Cancer Research. Fantastic people. If you would like to talk to them about the AI platform, please do. And we have structured the data so it can be easily explored and cross-linked. And we have built intuitive tools that allow researchers to identify patient subgroups, run analysis, and visualize tissue images all within the same environment. So in summary, I hope that I have illustrated how molecular pathology underpins the modern clinical cancer research, linking tumor biology to treatment decisions and outcomes. Our work focuses on three main themes: stratification, using biomarkers and algorithms to match the right patients to the right therapies; molecular dissection, understanding how tumors respond and adapt across different subtypes; efficacy, identify biological endpoints that tell us early on whether new therapies are working. So our team brings together expertise from multiple disciplines, and most of what we do is hypothesis-driven, grounded in biology, informed by oncology, and always mindful of the patient impact, including treatment-related toxicity. So before I close, I really want to sincerely thank all the patients who took part in our studies and contribution and trust make this work possible. I'm also deeply grateful to the many colleagues and collaborators who have helped shape this research and continue to inspire new ideas. I've had the privilege of being mentored by some truly exceptional supervisors whose guidance have profoundly influenced my career. And I'm equally grateful to my students and team members whose energy, creativity, and dedication drive much of what we do today. It's a privilege to work alongside them and to help support the next generation of researchers. So thank you for listening, and I will be very happy to take any questions now.
Maggie, thank you very much indeed. That was an absolutely fantastic lecture, really interesting. If we had a live audience, you'd be hearing the sound of lots and lots of clapping just now in appreciation from the audience. Can I remind audience attendees that we do have a question and answer box at the bottom of your screen. It should appear with Q&A underneath it, or if it's not there, if you click on the circle with more underneath it, you should be able to see the Q&A box in that menu as well. Please do enter in your questions into the question and answer box, and I will read out your questions and Maggie will answer them. If I could kick off with a question, please, Maggie. You mentioned the treatment with endocrine therapy leading to an adaptive response with an increase in expression in ESR1 and HER2. I was going to ask you if you've looked into the mechanisms involved in that adaptive response.
No, no, because I would love to. So in terms of mechanisms, it is because it's a human tumors and then we do in silico. So what I have looked at is the molecular profiling, the data, but I would love to work with a basic scientist to actually look at the functional mechanism, if that's what you meant. I think there's several very large groups in US, Carlos Arriaga, except they have extensively worked in research in terms of is pretty much a scenario that long reported by if you are co-expressing ER and HER2, that is a mechanism that potentially that would be a crosstalk for endocrine therapy. That is kind of like shown by animal models and function. But there was if that's linking to human data, it usually is in a very much a biobank observational studies and observe this expression. So I think this is probably one of the first study we've shown that is actually a signal on these in a very early setting and endocrine therapy, 2 weeks of endocrine therapy, but we haven't really worked systematically with anyone to actually look at the mechanism in that 2 weeks of endocrine therapy. So I would love to talk to anyone who may be interested to do that. But we also have this data that we can actually work together, look for the targets and then look at it together.
Okay, thank you. That's a good answer. Okay, so we have some questions now. First question is from Graham Murray, who says, many thanks for an excellent talk. How do you convey the complexity of intra-tumor heterogeneity in a clinically meaningful manner?
It's a very hard question. Um, that first, if spatial profiling intratumor heterogeneity, I think many of us is already in audience and here is actually probably running similar experiments in many tumors, and anyone who have run that would know that that is like massive data that you can generate. So it is a very fantastic research tools, but in terms of clinically meaningful tools, as I mentioned, I tend to do a hypothesis-driven biology. So if in terms of ER-positive breast cancer tumors heterogeneity, I would I have an active, so this is truly biased. Everyone knows me that I'm very much interested into islands of resistance, which is a term that's suggested by Mitch Darcy, but what I mean is I think intratumor heterogeneity plays a key role in terms of studying the on-treatment response. So I think for the next, what I would like to develop as a next direction in terms of translating that intratumor heterogeneity work in the clinical tool is to apply it on studying whether some tumors actually have showing homogeneously or any heterogeneity in terms of the response to the treatments, which is what I have demonstrated in the ER-positive, HER2-positive, but I'm also extending in POETIC trial to look at whether patients who actually have potentially considered to be in the average value in Ki67 being a low risk, but actually have recurrence, maybe that is a patient that actually have heterogeneity. And we would use as a high plex dimensional data and a support, and then try to find a targeted panel that may be actually capturing that scenario. So I think, so I give a long answer to a short question, but I think it's more like intratumor heterogeneity tool could be help us to actually identify who may be, why some of tumor not responding. But then similar tools as that is, we need to find a targeted signal that can help us to actually translate into a tool. And I think multiplex IF panel or even dual signal immunochemistry could be one of the best tools that we can apply. But what I start is actually applying a very high dimensional spatial point to at least like understand whether the biology mechanism capturing that that resistant sensitive is actually true in the biology. So I think multiplex IF and dual staining immunochemistry would be a very good way to look at the intratumor heterogeneity, additional pathology, of course.
Okay, thank you. Next question from Monica Kundratowicz, who asks, has there been much discussion of the practicalities of on-treatment testing, i.e. sampling or changing of the treatment modalities?
There have been a lot of discussions among the us in the trial list in terms of what kind of practicality we can measuring as being a research tool in clinical studies. And Ki67 is one of the single marker. Ki67 is one of the most discussed marker that we have discussed among in the ER positive breast cancer. In terms of practical, and then I think there is a lot of interest in terms of growing interest after the Poetic A, and also the German ADAPT trial had demonstrated that on treatment, Ki67 plays a very important role in the predictive tool. But in terms of practicalities of pathologists, I think there is also a different discussion whether the pathology department can support it. So I think it would be, I don't know whether you mean that practicalities here is about the pathology supporting or, so I think, I'm trying to think of a political correct statement here. So I think there's a lot of interest, and I think before we actually translate to, we are trying to demonstrate that this is important. I think, and we are just starting to generate evidence to support that on treatment profiling is important. So for practicalities, I think it would be very much a needed to discuss among with pathologists and clinicians whether they have interest in pathology. Is this even possible in the standardization, etc. I think it would be great if we can actually come together and talk about this as a group. I know when the 2009 paper that came out in the Ki67, it was raising a lot of interest from clinicians, and then we have Icon Mishdasa leading the working group to actually standardize Ki67, which really jumpstart in terms of how to incorporate Ki67. I think we are now at the time where we can actually maybe follow the legacy, and maybe we can discuss how we can actually standardize this on treatment practice, if there's any interest from the audience here.
Yes, I think so. I do agree with you there. Okay, so our next question is from James Morris, who says, another way in which breast cancer led the way was the observation that the longer the breast ducts were occupied by lactose fermenting bacteria, the less likely cancer was to arise. There is also no evidence that the microbiome in general influences chemotherapy response. Do you envisage that the breast intra-tumor microbiota will be integrated with these markers to influence choice of chemotherapy in the future?
So this is not the area that I have researched a lot, or I would not say I know about microbiota marker in breast cancer that much. But I know that there is a lot of interest in looking at this, and I agree with this comment. I think could be, but it is quite hard to test, I think. So far, I haven't seen studies looking at the microbiota I think it's partly because it's hard to analyze the microbiota, but the data we have, because some of these data now we are looking at the tumor, many of these samples that we have analyzed is about the tumor expression, and we have generated a link outcome. But if the short answer is I don't know, but I'm looking forward to actually see emerging results on this. The hard part is I think is we generating this data that is suitable to apply this microbiota data. And the samples is there, but I think it would be a long way for actual, long way, but I will be happy to support anyone who is interested to accept the samples and we generate the data that is support the assays that can actually apply those signatures that actually capture microbiota. Because I think the current assays, the data that the field have generated is very much about tumor, etc. So I think it will be important, but I think it is probably is going to have to be related to certain therapeutic, which is you mentioned chemotherapy, but I don't know. Looking forward to see the results. Yeah.
Yeah, it's still a developing field, so I think that answer is appropriate. So thank you. Okay, our last question is from Faye Cafferty, and Faye says, "Thank you, Maggie. You talked about breast cancer leading the way in this field. How do you see this type of work progressing in less common tumor types where such large cohorts are not available?"
I think this is like related to that question, but also related to how can we apply these high profiling data on a very rare cancer. So I talk about several different technologies, right? So and I'm also starting to involve in some sarcoma studies. So I think for the classical bulk high gene expression data, we have pretty good way to apply some of this methodology on rare cancer where I tend to not to. So for example, several layer to this question. So if the question is about how do we develop gene expression based or DNA based signature to predict outcome in rare cancer, that is very hard to actually develop it as if in breast cancer because the sample size and stat would be very hard. So how I approach with someone or project with sarcoma is that I come from a hypothesis. So it's basically unsupervised. Just apply this, just try to look for patterns and then apply some of this method that is like a single sample predictor and all these. So then actually then the resulting gene expression signature, evaluating clinical outcome would not be influenced by the small sample size. So I would not do supervised clustering, for example. I would do unsupervised clustering, find an expression pattern, and also like look for hypothesis really specific for that. For spatial, I think it would be very difficult to look for pattern for a small, but then for rare cancer, I think it's always hard to actually do all these, but I think it's probably apply the methods. For spatial work, I will look for it as but in a good way for spatial. Sorry, for spatial omics, maybe rare cancer is a good way because you can do all the samples, right? So now if you only have a trial with 38 patients, you can do spatial omics in a very cheap way, where now you actually even look at it in a more detailed way. So I think there's a pros and cons. If you're looking at bulk, looking for signatures, upfront, probably rare cancers would be a disadvantage. But then if you are looking for spatial work, rare cancer maybe even allows you to actually replicate the entire trials using the entire trial examples, not like a subgroup. But then you can do this high dimensional spatial data because it's cheaper to do the entire cohort.
Thank you. I think that's a very good answer. Okay, so we do have a tradition of finishing on time, so we'll stop there. And I'd just like to say a final thank you to Maggie for an absolutely fascinating lecture, really good lecture. I thoroughly enjoyed it. I suspect almost all the audience would join me in saying that they also thoroughly enjoyed it. So thank you very much indeed, Maggie. Thank you.
Thank you. Thank you for inviting me. Thank you.
Thank you very much for preparing this lecture and giving up your time for us. So thank you. I'd like to finish by mentioning our next lecture. Our next lecture will be given by Peter Schirmacher of Heidelberg in Germany, who will be talking about hepatobiliary carcinogenesis, and that will be on Wednesday, the 12th of November, with a starting time of 9 a.m. And with that, I would like to say thank you and bow out as this is the end of the session. Thanks very much, everybody.